Hello students, today let us discuss about nasal polypi or nasal polyps. So what are nasal polypi or nasal polyps? They are non-neoplastic masses of edematous sinonasal mucosa. They are usually pedunculated, hypertrophic, edematous mucosa. They are fleshy, tear-shaped, painless and benign. Depending upon the site of origin, there are two varieties of polyp. Number one, bilateral ethmoidal polypi. Number two, entroquanal polyp. Let us first discuss about the ethmoidal polyp. So what is the etiology of ethmoidal polyp? Exact etiology is not clear, but allergy is considered to be the most common cause. It is also associated with conditions that cause long-term inflammation of sinuses like chronic rhinosinusitis, asthma, aspirin intolerance. Just note that 70% of patients with asthma have associated nasal polyps. 36% of patients with aspirin intolerance have nasal polyps. Semter's triad is a triad of nasal polyps, asthma, and aspirin intolerance. Almost all cases of allergic fungal sinusitis have nasal polyps. Cystic fibrosis is a genetic disease causing nasal polyps in children, in addition to affecting lungs and pancreas. If you see bilateral nasal polyps in adults, it may be due to allergy, but if you see bilateral nasal polyps in kids, it is not due to allergy, it is due to cystic fibrosis. But they usually occur in the Caucasian race. Diseases causing disorders of ciliary motility like Cartagener's syndrome can also cause nasal polyp. Cartagener's syndrome is also called immotile cilia syndrome. There will be bronchiectasis, sinusitis, male and female infertility, and dextrocardia. Young syndrome is a rare condition that encompasses a condition of a combination of sinopulmonary infections and a reduced fertility due to azoospermia. Church-Strauss syndrome is an autoimmune disorder in which all affected individuals have history of asthma and allergies. Mildly affected individuals develop nasal polyps or skin lesions. Features of this disease are asthma, fever, eosinophilia, vasculitis, and granuloma. Let us discuss about the pathogenesis of nasal polyp. Due to inflammation of nasal mucosa, there is increased vascular permeability. Due to this, there is collection of extracellular fluid resulting in edema of normal nasal mucosa. This edema leads to narrowing of the ostium as well as prolapse of normal mucosa from sinus. Due to repeated blowing of nose for clearing your nasal secretion, it causes decreased nasal cavity pressure, and here Bernoulli's theory is applicable. So it increases the size of the polyp and pull down the polyp. Just know that in Bernoulli's principle, there is lowering of fluid pressure in regions where flow velocity is increased, like flow through a construction. Regarding pathology, in early stage, the surface of the nasal polyp is covered by ciliated columnar epithelium. On exposure to atmospheric irritants, it undergoes metaplastic change to transitional and squamous epithelium. Large intercellular spaces in the submucosa is filled with serous fluid with infiltration with eosinophils and round cells. The common sites of origin of polyps are uncinate process, bulla ethmoidalis, ostia of sinuses, medial surface and edge of middle turbinate. Now, what are the symptoms of ethmoidal polyps? They are runny nose, persistent stuffiness, postnasal drip, decrease or absent sense of smell, facial pain or headache, mass protruding from nostrils, and snoring. What are the signs? On anterior rhinoscopy, polyp appears as smooth, glistening, grape-like masses, often pale in color. It may be sessile or pedunculated. It is insensitive on probing and do not bleed on touch. Ethmoidal polyps are multiple and bilateral. Long-standing cases present with broadening of nose and increased intercanthal distance. This is a diagram showing left-sided ethmoidal polyp. Now, regarding diagnosis, how do you diagnose ethmoidal polyp? Diagnosis is done by number 1, clinical examination, then nasal endoscopy. One can also do imaging studies like X-ray of the paranasal sinuses and CT scan of the paranasal sinuses. Allergy tests are also done, and if the patient is a child with bilateral nasal polyps, we have to do tests for cystic fibrosis. One test that can be done is your non-invasive sweat test. Biopsy is done for any mass suspicious of malignancy. Regarding treatment for ethmoidal polyps, the conservative treatments are antihistaminics to control allergy and antibiotics to treat infection. Nasal corticosteroid sprays and oral corticosteroids like prednisolone and antifungal medications for fungal allergies are the other conservative treatments. Injectable steroids are also used if the nasal polyps are severe. If medical treatment doesn't shrink or eliminate polyp, then the surgical options are number 1, simple polypectomy. It is done when there is 1 or maximum 2 polyps. The other options are ethmoidectomy. There are 3 types of ethmoidectomy. Number 1, intranasal, number 2, extranasal, and number 3, transantral ethmoidectomy. So, when is intranasal ethmoidectomy done? It is done when the polyps are sessile and multiple. If recurrence occurs after intranasal ethmoidectomy, we go for extranasal ethmoidectomy. Transantral ethmoidectomy is done when the ethmoidal polyp is affecting maxillary antrum. The 5th surgical treatment is your functional endoscopic sinus surgery. It is the modern and advanced surgical treatment for ethmoidal polyp. Now let us discuss about enteroquanal polyp. It is also called Killian's polyp. Enteroquanal polyp originates from the mucosa of the maxillary antrum. It grows into the nasal cavity and guana and may extend up to nasopharynx and even oropharynx. Thus, it has 3 parts. They are antral, nasal, and guanal. So, it is usually trilobed polyp. Enteroquanal polyp is usually single and unilateral. It is seen in children and young adults. Exact etiology is not known, but nasal allergy coupled with sinus infection is incriminated. What are the symptoms of enteroquanal polyp? They are unilateral nasal obstruction. Bilateral obstruction is seen when the polyp grows into nasopharynx. Voice is thick and dull. It is also called hyponasal voice, and there will be presence of nasal discharge. What are the signs of enteroquanal polyp? Enteroquanal polyp grows posteriorly, so it may be missed on anterior rhinoscopy. Why does the enteroquanal polyp grows posteriorly? The reasons are number 1, mucociliary flow is directed posteriorly. Number 2, accessory ostium through which the enteroquanal polyp comes out is located more posteriorly. Number 3, effect of gravity when lying down. Number 4, Inspiratory airflow is more than expiratory airflow. Number 5, due to Bernoulli's effect. When an entroguanal polyp is large, a smooth grayish mass may be seen on anterior rhinoscopy, which can be moved up and down with a prop. Posterior rhinoscopy may reveal the mass in the guana or nasopharynx. When large, it may hang down behind the soft palate and present in the oropharynx. So this is a diagram showing an entroguanal polyp, and a part of it is hanging down in the oropharynx. So what are the treatment options for entroguanal polyp? Treatment of entroguanal polyp is polypectomy by avulsion method. If recurrent, Calwell-Luck operation is done. However, the latest treatment is your endoscopic sinus surgery. This is a diagram showing an entroguanal polyp which has been removed. In this diagram, you can visualize the guanal part, the nasal part, and the nasopharyngeal part also is you can visualize in this diagram. Now let us discuss about the differential diagnosis of nasal mass. They are: number 1, ethmoidal polyp; number 2, entroguanal polyp; number 3, hypertrophic inferior and middle turbinate. They are usually pink in color and it is hard like bone. Then your encephalocele, meningocele, and glioma, which is usually seen in children. Malignancy, the appearance will be fleshy pink, friable, and it will bleed on touch. And lastly, rhinosporiodiosis. So this is an endoscopic view of a guanal polyp left side. Lastly, one should know the difference between entroguanal and ethmoidal polyp. So in this diagram, you see the difference in age. Regarding entroguanal polyp, it is more common in children, and ethmoidal polyp, it is common in adults. Etiology: entroguanal polyp, as we have discussed earlier, it is usually due to infection, and ethmoidal polyp, it is due to allergy or multifactorial. Entroguanal polyp is usually single, ethmoidal polyps are multiple. Entroguanal polyp is unilateral, then your ethmoidal polyps are bilateral. Entroguanal polyp originates from the maxillary sinus, ethmoidal polyps originate from the ethmoidal sinuses. Entroguanal polyp grows posteriorly towards the guana, ethmoidal polyp grows towards the anterior nares. Entroguanal polyp is usually trilobed, it may be two-lobed also. Ethmoidal polyp, they are multiple small and grape-like masses. In entroguanal polyp, the obstruction is unilateral. Ethmoidal polyp, the obstruction is usually bilateral. Entroguanal polyp, the history is relatively short, but in ethmoidal polyp, history is relatively long. Recurrence is uncommon in entroguanal polyp, whereas recurrence is common in ethmoidal polyp. And regarding treatment, entroguanal polyp, treatment is usually surgical, and in ethmoidal polyp, we can first try medical treatment. So this completes your discussion on the nasal polyps. I hope you get benefited with this discussion. Thank you.